Dr. Ault, welcome. Of course, we're here at ASCRS 2025. Loving San Diego. It's been beautiful weather here the last few days. And you've been in the world of colorectal surgery now for decades. Obviously one of the top leaders in the field. You've been in charge of the board, I believe, at some point.
Correct.
But today we're really here to talk about what ASCRS has been working about from an educational standpoint. You have a leadership institute, is that correct?
Yeah, so we have something we call the Surgical Leadership Institute that the society started a number of years ago that I now have responsibility for.
Can you kind of break it down for us? What is the Leadership Institute? What's the purpose of it? And then what are you trying to accomplish from a society standpoint?
Sure, so from the society standpoint, we recognize that we have basically a continuum of folks that start from early career, from our students, our residents, our fellows, mid and early career folks, and how do we create a leadership journey for them and provide a home for them to teach them the skills that they would need to be successful, whether it's in their hospitals, in their practices, and in their institutions. So we have created this process, essentially a journey, if you will, that we look at everything starting from our fellows course, our fellows career course, which usually happens every fall, and where we talk things about negotiating a new contract, how do you get started, and then how do you start a practice, all those things. Then we have a mid-career course, which is for surgeons that are out 3 to 7 years in their career. Talk a little bit more about how you start to define your leadership style. How do you, do negotiations for things that you need in the hospital? How do you create a business plan, for example, in that early career stage as you get yourself established? And then we recognize that the mid-career folks that may be transitioning to something different or a higher leadership role, they had different needs, and so we're developing a mid-career course as well. The Institute also we're looking at a piece as well for our advanced practice providers, right? So we're really trying to provide a home for everyone that's a member of our society for some part of their leadership journey to be able to have some training and to have some exposure.
And as somebody that's been in the field for this many years, when you look at, let's say, a fellow and they're going into practice, what do you say to them in terms of what they need to be looking for, not just from an institute standpoint, but personally, what have you learned that you would tell them to do?
My number one piece of advice to a fellow going out is, first off, if you're joining a practice, make sure you get to know the people you're joining first before you sign your contract, right? Because that is so important. It is your first job to me is the people you are going to work with. Look for some folks that are willing to mentor you a little bit, that are willing to invest in you individually and aren't really just hiring you because they need another body, right? It's so important to have that, especially early in your career. Knowing that you can call someone that's going to come and give you a hand in the OR if you need it, or if you have a difficult case, to be able to walk through that with them and not feel like you're, kind of pulling teeth to get them to help you.
And along those lines, what have you seen to be the biggest mistake a fellow has made coming out?
Biggest mistake I would say is probably jumping too quick, right? Jumping too fast. Really do your homework, get to know a little bit about not only the individuals, a little bit about the practice. Sometimes if you're joining an academic, it's kind of more straightforward. There's not a lot you're going to negotiate for or do much there. It's, as I said, very straightforward. But again, it's jumping too fast and thinking it's like the perfect job without doing their homework.
Is there a perfect job?
I don't think there's a perfect job. I may be an exception to that rule. I thought I've had some, really good job. I've been at USC my entire career and been very fortunate there, and I've had a very good career there. But every job is probably going to have some drawback to it. And again, it's like anything else. It's like when we talk with our patients, right? It's about risks and benefits of an operation. Same thing. Like, are you willing to tolerate something that maybe is not as attractive to you because there are other things that are very attractive to you in that job search, right? And so for a lot of our fellows, I think it's about location and where family is and things like that. And sometimes it's even taking a job first that may not be that perfect job to get them where they want to go. So.
Yeah. And in terms of mid-career, how do you look at them differently?
Well, I think for folks that are in the mid-career, I think it's really about they're trying now potentially maybe to pivot slightly in their career, maybe take on some additional roles, whether it be in hospital leadership or in their health system leadership, and then how do we provide tools for them so they can succeed in that and provide a home. Now, look, there are a lot of groups out there that do leadership courses. If you're in an academic place, your universities do it, but American College of Surgeons, there's a bunch of other people that do courses. But we really wanted to provide something that was a little more colorectal focused, and that, as participants came, they really knew they had a home with us, and it's people that they know from our society, et cetera. We're, for the most part, colorectal surgeons we're not an expansive group in the country, and it's very interesting after you've been around for a while, you get to know a lot of people, and I think people feel comfortable in that situation and coming and talking about problems that they're facing. How do we help them develop plans to solve those problems there? I think they're a little more willing to have a more open conversation.
And you've been able to work your way through the entire system. You've been all the way at the top, you've been on the board, you've been leadership here, multiple leadership positions. What was the secret you found to working your way through the system?
Well, for me, again, one, it's be engaged, right? So you got to engage yourself. If you want to get involved and hold a leadership role or a committee chair or whatever, it's engaged, number one. And when you can't just sign up, it's about showing up, right? What did they say? 85% is just showing up. But it's really about not only showing up, but it's about then engaging and being active, participating in the work that needs to be done. You can't just go in for the ride. You've got to contribute, and that's was for me the success. Sure, there was probably some serendipity along the way. That's the way it always works a little bit. Whether it's becoming a program director and getting involved in the Program Directors Association, being president of that, which then got me appointed to the American Board of Colon and Rectal Surgery, and working up through that and being president, which got me appointed to the review committee. And so there are things that you just kind of can put yourself in position for, but I think people recognize when you are engaged or involved and willing to contribute and being willing to roll up your sleeves and get the work done.
Yeah, I think you say serendipity, but in my experience, as you said, it's being there. Because putting your face out there, people, as we sat here, you've had probably half a dozen people walk by and wave at you. So I think it's that smile of yours that kind of keeps you going. But you also have ASCRS U, right, and you're in charge, you're the dean, correct?
Yeah, so it's interesting. We call it the dean, but it is really I have responsibility at the society level. I'm just coming off my final year as an executive council as a member at large, and so I've been appointed to be the dean of ASCRS, and really it just means I have the responsibility for the university. And basically, ASCRS is our online app, our education app. And it is a repository right now of things like our textbook. It has the fundamentals of rectal cancer surgery on there. It has, if you subscribe, you can get our self-assessment, the CARSEP program on there. There's a number of webinars and other videos. So it's kind of a repository for educational materials right now. But I think, we're looking to take it to the next step.
And when you say the next step, what does that look like?
Yeah, and so I think, a lot of exciting things happening, and just turn around and look, right? You look at artificial intelligence, machine learning, you look at all the things that are happening around us, and we're starting to use that some in medicine, but the way I think about it is this: we do a lot of different things. We do self-assessment, whether it's in CARSEP, we do continuing certification for our board certification. So we do a lot of educational things. Wouldn't it be great to be able to take the data mine that data and say, okay, Glenn, we've noticed a pattern here that you struggle in this area, and it's then creating a personalized educational tool for that individual surgeon. So they could sign, this is pie in the sky, and we hope to get there, but if the surgeon signs on and data is available for them, it can say, you need help in colon cancer screening, or we've seen that you don't perform as well there. Or the system could ask you a series of questions, maybe 6 to 8 questions, and based on those 6 to 8 questions, tailor a topic of education for you in colon cancer screening. Let's stay with that one, right? It'll assess your current knowledge. It may ask you some interest or where you think your strengths and weaknesses are, and based on that, be able to tailor, rather than going through, let's say, an hour lecture or an hour module on colon cancer screening, it potentially could tailor something, right? What we know now, I think, today's generations, right, and as they come up, they're very on-demand people, very different, Yeah. I laugh, right? I used to read textbooks, right? Who reads a textbook anymore, right? In the sense that, and even my daughter who's in medical school, she said, we have these textbooks, Dad, and I've only opened one of them, right? And it's very different. So they're a very on-demand generation. So what we're looking to do is have them be able to open that app and say, I want to do this, ask them a series of questions and really tailor something, and they feel that they're getting something personalized, not just opening a video and replaying a video that may have happened at the annual meeting or in some other venue.
No, absolutely. And I'm going to turn a little bit, just pivot, because we did want to touch base on some clinical issues. Sure. And we had mentioned, or we had a discussion previous about the age in which we're seeing more and more colorectal cancers. I think ASCRS is really worried about that. What are we seeing, and why do we think this is happening?
So what we're seeing really is more and more young people presenting to us with colon and rectal cancers. And it's basically, even though it remains rare, its incidence has doubled since the 90s. So we know that we're seeing more and more young people. Now, why is that happening? There's a lot of theories out there. It's everything from our diet to sedentary lifestyle, obesity in our country, and it's not just in the US, we're seeing it in other countries too. There's a lot of work being done, for example, in the microbiome, and is what is happening, from a physiologic standpoint in our gut, potentially driving some of this. It's probably a combination of many things, but I would say that, and that's really where a lot of this is looking. At the society level, we're really looking at how we begin to advocate and make or raise awareness with younger populations. New York Times has covered it. I think there was a story in NPR at the end of April actually on the same thing. And so how do we participate in those kinds of outreach efforts to advocate for younger people? Because we're young.
Well, yeah, could you define younger people when you say that?
We're talking about people that are under the age of 50, basically. Okay. And in the United States today, current screening guidelines start a screening at 45. But we're seeing it, in 40-year-olds and 30-year-olds. And certainly we know there's a genetic component. There are some families that we know there is a genetic predisposition. We're not talking about those folks. Those folks we should capture and we should be really on top of. It's really the what we call the sporadic cancers that are happening in these young people. And again, why is that happening? It may be microbiome, it may be their lifestyle, it may be a number of issues. But the challenge I think for young people is, and we've all been through it, like, I'm young, I'm invincible. So what, I have a little, stomach upset or abdominal pain, and yeah, it'll pass. Or yeah, I had some rectal bleeding, it's just a hemorrhoid. And it's really about raising awareness when you have some of the classic symptoms to really push your primary care provider, push your doc, get in to see the right people, because of course we're in tune to it. Our biggest challenge is getting, say, primary care providers to be in tune as well. So that advocacy is not only with patients, but also with providers.
And when you say those basic symptoms, we obviously as surgeons, we kind of know what those are, but could you state those real quick? Like what would worry you if you were 35 years old? What symptoms would you start having that would make you worried that you should probably go get that looked at?
It's very similar symptoms that an older person sees, but because we're younger, we discount them, right? It is things like abdominal discomfort that doesn't go away. Sure, every once in a while we get some abdominal pain, or you eat something and it doesn't sit, but something that persists, right? It's those symptoms that persist. So it's abdominal pain. It is a feeling of bloating, fullness, which again could be other things, but it could be cancer as well. Bleeding's a big one, right? I think if you have any episodes of rectal bleeding, that I think you really should get that checked out and make sure it is not something simple and benign, but that you don't have a problem. And then of course there's unexplained weight loss, that you're not expecting a weight loss, but that also happens in young people. And when that does, you really got to be concerned.
And obviously you don't have to have all those symptoms to be worried, correct?
That's correct, you don't.
And when you talked about microbiome, could you kind of define that for us and walk through when we talk about that, what do we mean? Because there's like almost a symbiotic relationship, right, between our gut now. We've really started to understand that this plays a much bigger role in how our body functions.
Yeah, it's interesting, right? So when you talk to lay people, like I have bacteria in my intestine and my colon, and yes, you do, right? And they are what we call they're good bacteria, right? And they are the bacteria that help us digest food and do things that we need to do and to produce stool, basically. The challenge becomes then when some of those bacteria either, become more prevalent in the bacterial population, or they produce toxins. Like there's papers out now that are looking at a toxin that E. coli produces, for example, or Fusobacterium. Bacteroides is another one, right? And if they are out of alignment or produce those toxins, there is evidence that they may lead to this early onset of colon cancer and upset what you would normally have as a balance in your gut. It's kind of the same thing that happens with Clostridium difficile, right? And so when you take antibiotics, right, and the C. diff now is more populous in your intestine, you can get a bad infection, and some people lose their colons because of that and get severe diarrhea. But it's a very similar process if you think about it.
Yeah, I know it was interesting. My background's in critical care as well. And if you get down to a single isolate, your mortality rate in the ICU skyrockets versus if you maintain a normal polymicrobial population within the gut flora. And it was the first time I saw it, I was at a college meeting, the first time I really saw it, because I think they poked the cecum of a rat and just let it basically go full fulminant sepsis, and it was more like it survived than if you got it to a single isolate. And it was unbelievable. Like, it was, your body can really survive a lot, but the colon health and the colon bacterial population plays a critical role that we really just did not account for.
And we're learning so much about it, right? I mean, it's almost like every year there's another paper that comes out that's looking at these bacteria, the toxins they produce. It's a little bit, we're still not entirely 100% sure, but I think we're getting closer, right? And I think the NPR article story that I spoke about actually came out of some work that was done right here at UCSD in San Diego.
Really?
Yeah.
And then let's back up a little bit more again. I mean, you've been doing this 35 years, 40 years. No, so you said less than that. So, but in all that time, what have you learned? Like, what did you go through and you say, this is what I learned as a wisdom standpoint, meaning that textbooks aren't going to teach you this, but it's something that you've witnessed, you've seen, be it a clinical scenario that you know that this is where it just falls out of the algorithm, right, or something that how to deal with patients that, if there's a little trick or a hint that other people aren't just going to pick up on. What would you say that little piece of wisdom to share?
Well, my wisdom is anybody that's a learner for me or anyone that I teach, always have your eyes open, be astute, right? Too often I think we get tunnel vision and we expect things to happen a certain way. And as a surgeon, right? That happens 90% of the time, right? Appendicitis is going to present the same way, cholecystitis is going to be the same. But you have to be aware and astute when something doesn't seem off, doesn't fit into that algorithm. Be willing to have your mind open to other possibilities, right? Don't go down a track and get lost, get down a rabbit hole that you shouldn't be down, right? And the other part of that is just continual learning, right? And that's where for us, this ASCRS is going to come into it. We really want to be able to provide something like, if I want, like for example, like we just talked about the microbiome, right? And this is stuff that's evolving, right? And so people can Google Scholar or Google search now, probably get an AI summation if they wanted, but we want to be able to provide that in a very scientifically based format on the platform.
Oh, absolutely, absolutely. Yeah, I was thinking about, as you were saying that, it's been interesting to see how AI is going to potentially take all this information that we're talking about and convert it to actual treatment options and whatever in the world of colorectal. Besides the educational standpoint, what is being discussed at the colorectal, bureaucratic level of where we see AI fitting into colorectal surgery?
Yeah. I think at least the earliest applications we're seeing now is some of us are using it in our offices, right? It's voice dictation software. It's capturing basically the conversation that I'm having with my patient and then digesting that into a note. That still has to be edited. We're still finding a lot of errors in that, or at least I do. And it is also can produce a differential diagnosis for you as well. And there are some platforms that do that now. Again, I think that's, at least in the early stages, that's where AI is going to be very helpful in trying to streamline our work. I like it because it allows me to sit and have that conversation with you as my patient, rather than looking at the computer and typing, or or having a scribe or whatever else you have. And so I think that's exciting. As an educator, it worries me a little bit, right? Because I'm worried, at my stage in the career, I love it because I'm like, I don't need to learn how to write a note, but we're having conversations at the school level, like what happens to the student, right? The student still needs to learn how to do that history, do that physical, what are the right questions to ask, and if you let AI do that for you or generate the questions that you need to ask, I think that's where we get into trouble.
I think we were seeing that, and that problem was going before even AI. I mean, when I was in fellowship, I noticed that they no longer knew how to write orders, so they would go to the system, and the system would basically because they would just click the boxes, and they would click whatever boxes, because they never had to sit down and actually think through, I need to order this, I don't need to order this. It was just click, 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 order set, order set, order set, right. And you end up ordering a dozen more labs than you ever needed to, because you didn't have to actually stop and write down individual labs and think through why I was ordering them.
Right.
And now you're going to have an AI system that just generates it all for you.
Here's a classic example, right? That the medical record systems, you go in to put an order in for an NG tube, but guess what's also on that same order set is a PEG tube. And you can click a PEG tube, which is very different than placing an NG tube, right? So there's clearly some education that has to happen, and that's what worries me a little bit. We just want to make sure that we're still giving the foundational skills that students and residents and fellows need before they get to be attending. So at my stage as we get on in our careers, right? I love having that AI being able to help me with that because it allows me to have that great conversation.
Yeah, no, I think that's one of the biggest things is you don't have to have that structured data. You can basically have a conversation. We have a scribe feature in our app, and you can have this whole conversation. At the end, it's like it takes that and just converts it to exactly what you want without you having to specifically say, put this here, put this here, put this here.
Right.
That's amazing technology, and that's just beginning. So I just want to leave you one last point. So all of this knowledge, what is it that you want to be the take home for anybody that's going into colorectal surgery now? If you were just going to tell anybody coming in, like, here's what you should be thinking about for the next 10, 15, 20 years, what would that future look like to them?
I mean, I think what I would tell and what I say to my fellows now is, like, again, you've picked a great group to be involved in, right? I think our society, because we're small enough, that you get to know a lot of people. We're a really good community nationally. But I think it's, again, be willing to stay on the edge of innovation. There's going to be a lot. The technology, we're going to have to keep up with it. This isn't like, when I started, right? I mean, we were barely doing laparoscopic surgery when I started in colorectal surgery. So, and then, all of a sudden robotics comes out. I mean, it's being willing to have that open mind, to be open to that innovation, being willing to look at things with a critical eye and really advance our field to help our patients.
Well, Dr. Ault, thank you so much for your time. Once again, ASCRS is phenomenal, beautiful weather for you guys, and thanks for having us here.
Thanks for having me. Really appreciate the conversation.
Well, same, and welcome to the cutting edge.